video is brought to you by Dr. Barai. Please press on the subscribe button and the bell icon.
Hello everyone, this is Abhijit Barai. In this video I'm going to talk about migraine, which is a pretty challenging condition that we see in the emergency department, urgent care settings and in the GP practice. I hope you find it useful. And I'll talk about the symptoms, the signs, how to diagnose it, what are the different treatment options we have, and if there is any new information in the literature that can be useful or applicable to clinical practice. With me, I have Becky, who has got some really good knowledge and understanding of migraine. She's going to help me in preparing this presentation. Welcome, Becky.
Hello everyone. I am Becky. As always, it's a great pleasure to be here. Over the next few minutes, we are going to talk about migraine. Hope you like it. I know how amazing you are. Please press on the subscribe button below and do not forget to click on the bell icon to get regular updates. We will bring to you new exciting videos regularly for your education and entertainment. If you have any burning questions or awesome ideas, please write in the comments section below and we will get back to you as soon as we can. I can assure you that the next few minutes will be very informative and interesting. I will be with you till the end of the video. Let's start, shall we?
Yes, let's get into the depth of it. So first of all, what is migraine? Migraine can be a headache for the patient, and also it can be headache for the doctors because of the challenges that we face in the diagnosis and also in the management of it. Now, in the centerpiece is the headache, which is the main presentation, but there are some migraine where patient may not have any headache at all. And this headache is not a one-off headache, it is episodic. It comes and goes, comes and goes. It may or may not be associated with something called aura, and we'll discuss about it in a second. Patient can have photophobia, phonophobia, so they prefer to lie down in a dark room in a quiet environment. They can have nausea, vomiting, and it is disabling as well. Now, as I mentioned, the diagnosis and management both can be challenging. So we need to have a very good understanding of this condition so that we can help the patients. It's not a very unusual presentation at all. We see hundreds of patients every year. In the US alone, there are about 1.2 million presentations of migraine to the emergency departments and also in the urgent care centers. I don't know exact number in other countries like the UK or in Australia or New Zealand, but the number may be a representative of how many patients we actually see and deal with it. Now, as I mentioned, that it's not a very straightforward thing. It's a complicated thing. In the center piece of migraine is obviously headache, but patient can have other problems as well. So sometimes if the patient comes with photophobia, phonophobia, nausea, vomiting, we need to think, is it because of migraine or it is something else? There are a lot of differential diagnoses, so we need to keep a very open mind. Now, before we get into the diagnosis and management, I think let's have a quick look on the pathophysiology of migraine, why it happens, how it happens. If we can understand the pathophysiology, it will be very easy for us to give the treatment. So in earlier days, when I was in the medical school, we were talked about the vascular theory. Vascular theory is that patient has got vasodilatation that compresses the meninges and that can cause headache. So one of the treatment that was advised during that time was give some medication that can cause vasoconstriction, like the ergot alkaloids or hydroxyergotamine. However, in subsequent studies, it is proven that this theory actually does not stand. It is not proven to be true. So the latest theory is the cortical spreading theory. What it means is the patient has got the brain surface, especially the cortex, and the glial matter as well. There is some depolarization, and this goes on and on and on. This can cause inflammation to the covering of the brain, the meninges, and that is why there is this pulsatile and discomfort or pain in a localized area of the brain or head rather. Now, that theory actually seems to be quite near truth. And because there is some inflammation, if you give some anti-inflammatory medications, for example, some naproxen or some high dose of aspirin or ibuprofen, usually this is found to be very effective. Another medication that is used, and we'll talk about it in a few minutes, is dexamethasone. It is a steroid, and a steroid works very well in suppressing the inflammation. And so for the treatment and for the prevention, we can use steroids as well. So one of the things that we need to understand is the trigeminal vascular system. The migraine headache can be because of the involvement of the afferent fibers in the trigeminal ganglion. And that is why the pain can be in the frontal part of the head. On the other hand, the upper nerve root of the cervical nerves, they can be affected, and that usually gives a pain in the back of the head. A very important concept about the migraine is the sensitization. What it necessarily means is that with time, the threshold decreases. So there are some triggers, for example, stress, exercise, maybe starving. Initially, the threshold is high, so you need a very high amount of trigger to develop the migraine. With time, because of the sensitization, even with a small amount of stress, you might develop migraine. There are various MRI scan studies which showed that there is actually some structural changes in the brain of the patients who have got migraine. Some part of the gray matter is thicker, and in some part of the gray matter is thinner than other people who don't have migraine. We need to understand the role of serotonin in migraine as well. So the theory is that if there is a decrease in the serotonin, that can cause migraine. Or in other words, we can say that migraine is associated with reduced serotonin. So the treatment is simple. Just increase serotonin. Either you can give some drugs like some SSRI, SNRI, or tricyc antidepressant like amitriptyline or nortriptyline. That will increase the serotonin. The other thing you can do is give some sumatriptan. Sumatriptan is a serotonin agonist. So it will work like serotonin, and thus the headache can subside. It doesn't happen in 100% of the cases, but most of the cases that is the clue of the management of migraine. As you can see in this image, that on the brain surface there is some depolarization. It is not as strong as is found in case of the seizures or epilepsy, but it is similar type of depolarization. And actually, seizure can be a complication of migraine as well. So we need to keep an open eye on this special condition. Now, a little bit of epidemiology, and Becky, could you please tell us about epidemiology of migraine? Thank you.
Migraine is a common disorder that affects up to 12% of the general population. It is more frequent in women than in men. The migraine attacks occur in up to 17% of women and 6% of men each year. Migraine without aura is the most common type, accounting for 75 to 80% of the cases. Migraine is most common in those aged between 30 and 39 years. Migraine also tends to run in families. In fact, the incidence of migraine is 3 times higher in patients with a family history of migraine than those without a family history of migraine. Although not fatal, migraine is a major cause of disability. It is ranked second worldwide in 2016 among all the diseases with respect to years of life lived with disability. Migraine may have association with some other diseases as well. The data from several retrospective nationwide cohort studies in Taiwan, all from the same group of investigators, suggest that migraine is a potential risk factor for Bell's palsy, sensorineural hearing loss, and oculomotor cranial nerve palsies. However, independent reports are needed to confirm these associations.
That's great. So that's a great epidemiological information that may be useful to understand the next few slides. Now the clinical features, what the patient presents with and how we can diagnose it. So one of the mnemonic that we use in medical school, and I think it is still applicable in clinical practice in a busy clinical shift, is pound. And so this is what happens in migraine.
There is this great mnemonic to remember the clinical features of migraine. It is pound as in pounding headache. Here, P stands for pulsatile. O stands for onset 4 to 72 hours. U for unilateral. N for nausea and vomiting. D for disability. When you struggle to remember the features of migraine, just remember pound. Easy peasy.
Yeah, that's great. So as you can see in this animation, that the patient has got pulsatile headache, and that usually unilateral, either on the right side or left side. But as I've mentioned, it can be in the occipital area if the upper cervical nerve roots are affected. And usually the patient can have some nausea, vomiting, and that can affect their day-to-day activity, their professional activity, their social activity. So it is a disabling condition. Um, and when the patient cannot cope, then they seek the medical help. They come to the hospital or get to the GP or the urgent care centers. Um, Now, there are four phases in the diagnosis of migraine. These are the first patient develops a bit of prodrome. We will get into further details, and Becky will talk about it. Then the patient develops aura, as we have mentioned. 25% of the patient develop aura, and 75% of the patients do not have aura. Then is the actual phase, which is the headache. And after the headache subsides, patient can develop postdrome. So Becky is going to tell in full details about all these four phases of migraine headache. Becky, after you.
A typical migraine attack progresses through 4 phases. These are the prodrome, the aura, the headache, and the postdrome. The first phase of migraine is the prodrome. The prodrome occurs in up to 77% of migraine patients. The prodrome consists of affective or vegetative symptoms that appear 24 to 48 hours prior to the onset of headache. Frequently reported prodromal symptoms include increased yawning, euphoria, depression, irritability, food cravings, constipation, and neck stiffness.
Wow.
The next phase is the migraine aura. About 25% of people with migraines experience one or more focal neurologic symptoms in the second phase, called the migraine aura.
Mhm.
The traditional teaching is that the migraine aura usually precedes the headache.
Yeah.
However, the prospective data suggest that most patients with migraine experience headache during the aura phase.
Ah.
The typical migraine auras are characterized by a gradual development of symptoms. The duration of aura is no longer than 1 hour. Therefore, if the aura lasts for more than an hour, we need to consider an alternative condition such as a stroke.
Interesting.
During the aura, a mixture of positive and negative features may be found. Finally, aura is completely reversible. Therefore, if the aura does not reverse completely, we need to consider an alternative condition such as an intracranial catastrophe. The positive symptoms indicate active discharge from the central nervous system neurons. The typical positive symptoms can be visual, such as bright lines, shapes, and objects in the visual fields. The positive auditory aura include tinnitus, noises, and music. The positive somatosensory aura include the burning, pain, and paresthesia. The positive motor aura may present as jerking or repetitive rhythmic movements. On the other hand, the negative symptoms indicate an absence or loss of function, such as loss of vision, hearing, feeling, or ability to move a part of the body.
Right.
Auras are most often visual, but can also be sensory, verbal, or motor disturbances. The aura of migraine usually develops gradually over more than 5 minutes. Less often, the aura develops more acutely, that is, in less than 5 minutes. The acute onset of aura makes confusion with a transient ischemic attack, TIA, or stroke more likely.
Yeah.
The next phase of migraine is headache.
Yeah.
The headache of migraine is often but not always unilateral and tends to have a throbbing or pulsatile quality, especially as the intensity increases. As the attack severity increases over the course of 1 to several hours, patients frequently experience nausea and sometimes vomiting. Many individuals report photophobia or phonophobia during attacks, leading such migraine sufferers to seek relief by lying down in a darkened, quiet room.
Yeah.
Additional migrainous features such as osmophobia and cutaneous allodynia may occur during attacks. In the adults, an untreated headache can last as little as 4 hours and as long as several days. Many attacks resolve in sleep. The last phase is the migraine postdrome. Once the spontaneous throbbing of the headache resolves, the patient may experience a postdromal phase. During the postdrome, the sudden head movement transiently causes pain in the location of the antecedent headache. During the postdrome, patients often feel drained or exhausted, although some report a feeling of mild elation or euphoria. Let me repeat it. There are 4 phases of migraine. These are the prodrome, the aura, the headache, and the postdrome.
Excellent. That's a really good summary of all the clinical features, and it is useful for the clinicians to get into it. So by the time the patient comes to us, most of the time they have got headache. But if the patient is known to have migraine, probably they will know from prodrome and aura that they are getting there. And usually the headache is the main symptom that bring the patient to the emergency department or urgent care settings or to the GPs. But again, when the headache subsides, we need to tell the patient about the postdrome as well. Fantastic. Thank you very much. Now, let's get into further details about aura. Becky has already mentioned a lot of things about aura, positive and negative symptoms. And it can be visual, it can be auditory, it can be language, it can be sensory, or it can be motor. Now, the visual aura, auditory aura, sensory aura, they don't present at the same time. They usually present in a different times. So if the patient develops visual aura, it might, either positive or negative, it might disappear, and then they develop the maybe sensory aura or motor aura. So Becky is going to talk us through these various types of aura in further details now. Thank you, Becky.
Sure. Thank you. As I said, there can be various types of aura such as visual, auditory, somatosensory and motor aura. Now a little bit more details about the visual aura. A visual aura classically begins as a small area of visual loss, often just lateral to the point of visual fixation. It may either appear as a bright spot or as an area of visual loss. Over the following 5 minutes to 1 hour, the visual disturbance expands to involve a quadrant or hemifield of vision. Along the expanding margin, geometric shapes or zigzagging lines often appear. The shapes account for one of the common names for aura, the fortification spectrum, because of the resemblance of the aura to the walls of a medieval fortress. We will show you animations of the fortification spectrum in a second. The positive visual phenomena may assume a sickle or C shape, expanding over time toward the peripheral visual field, leaving a scotoma or area of complete visual loss in their wake. As the aura moves off into the peripheral visual field, it often assumes a shimmering or scintillating quality. As the aura resolves, vision usually returns first to the areas of central vision initially affected by the aura. Now, let's talk about the sensory aura. The sensory aura is also common and typically follows the visual aura within minutes, although it may also occur without the visual aura. A sensory aura usually begins as a tingling in one limb or on one side of the face. As the tingling sensation migrates across one side of the face or down the limb, numbness is left in its wake that may last up to an hour. The sensory aura may also move inside the mouth, affecting the buccal mucosa and half the tongue. The slow spread of positive symptoms such as scintillations or tingling sensation followed by negative symptoms such as scotoma or numbness is quite characteristic of migraine aura and is not typical for an ischemic event. A special type of aura is the language aura. This is less common than the visual and sensory auras. The language aura is also known as the dysphasic aura. Language auras cause transient problems that may run the gamut from mild wording difficulties to frank dysphagia with paraphasic errors. I find motor aura very challenging to diagnose and manage. In the rarest of auras, motor aura, the limbs and possibly the face on one side of the body become weak. It presents just like a stroke.
Right.
Because of information related to the genetic basis of the motor aura, it has been separated from the other forms of aura and classified as hemiplegic migraine.
Right.
The aura symptoms may occur either singly or in sequence, but they do not generally occur simultaneously, which means that the patient generally does not experience visual, sensory, language, and motor aura at the same time. If they do, please consider an alternative diagnosis. One thing is very obvious, that the aura does not last for more than 60 minutes. If they do, please consider some other diagnosis.
Excellent. Thank you. So that is a very good summary about the aura. So there are various types of aura, but as Becky has mentioned, that the commonest aura is the visual aura. And if the patient develops visual aura, that may be followed by the next step, which is headache, or they can develop a different type of aura. And when the patient develops aura, they know that they are going to develop headache. So either they take the treatment or they come to the hospital. Now, a little bit about fortification spectrum. So fortification spectrum is a type of negative symptom of a visual aura. So what happens is, in the visual field, they develop a C-shaped blurred image, and then gradually that blurriness gradually expands and the whole visual field gets obliterated. So that is the fortification spectrum. I tried to make some animations, but it did not go very well. But still, I think I will share with you. So you went to a holiday, and there was this beautiful afternoon. You are watching the sunset, and suddenly you notice that a part of your visual field is getting a little obliterated, and it is gradually expanding. That's quite worrying, and it may be the fortification spectrum. And gradually the symptoms subsided. He went to another beach to watch the sunset again, and you notice that the visual field is getting obliterated, and it is gradually expanding, and there is some zigzagging sign, and the whole of the visual field is getting obliterated. So this is classic presentation of fortification spectrum, which is a feature of the visual aura. Now, when we talk about aura, we need to talk about uh, the, the fact that patient can have aura without any headache. And on the other hand, patient can have headache without any aura. That happens in 75% of the cases. So in this case, the patient can have no headache, just aura, and uh, sometimes they present to the hospital. For example, if the patient has got hemiplegic migraine, they may not have any headache. They can have just hemiplegia.
Aura without headache is a special phenomenon that we need to be aware of. Migraine aura without headache manifests as isolated aura unaccompanied by headache. This is also known as migraine equivalent and diaphalgic migraine. In a Danish case study, about 4% had exclusively migraine aura without headache. Auras without headache may be confused with transient ischemic attacks, especially when they first present in older patients as late-life migraine accompaniments. The late-life migraine accompaniments are symptoms related to the onset after the age of 50 years of migraine aura without headache. The most common symptoms are visual auras, followed by sensory auras such as paresthesia, speech disturbances, and motor auras, such as weakness or paralysis. The most common presentation is gradual evolution of aura symptoms with spread of transient neurologic deficits over several minutes and serial progression from one symptom to another.
Yeah, so sometimes it is really challenging diagnosis, and if the patient does not have headache, the general perception is that aura is equivalent to headache. But as I mentioned, the patient can have aura without any headache. So if that is the case, sometimes we think about, is it a stroke? Is it a transient ischemic attack? We try to exclude those conditions before we come to the diagnosis of migraine. Now, there are some triggers, there are some conditions. These are not actually the cause, because the cause is what I have told you in pathophysiology. These are the triggers which can start development of the migraine. The commonest one is about 80% of the cases, the patient has got some emotional stress. The physical stress, on the other hand, is less commonly associated with migraine. This is emotional stress, which is more important. The hormonal influence is very important as a trigger for migraine. If the patient is starving, that can trigger the migraine in about, I think, about 60 to 70% of the cases. Weather, especially cold weather, that can trigger the migraine. Sleep disturbances, especially insomnia, can cause this as well. Now, the very interesting thing is we have talked about the not eating or starvation that can trigger the migraine. But at the same time, there are some foods, especially chocolate, red wine, and smoking. They can be associated with the triggering of migraine as well. The least common trigger is the sexual activity. I think that is associated with 5% of the cases of migraine, not much. Now, a few subtypes of migraine. The migraine can have, as I mentioned, patient can have aura, patient may not have any aura. In children, they can have a type of migraine which can be considered as the brainstem aura or brainstem migraine, or basilar migraine is another name. Usually, this is found in children between 7 and 20 years of age. Hemiplegic migraine is a special type of migraine when patient develops typical features like a stroke. The only thing is hemiplegic migraine, it does not last more than 60 minutes. So that is quite reassuring. Patient can have involvement of the eye. This is commonly known as retinal migraine, but also this is also called ocular migraine because it not only affects the retina, but also the ciliary ganglion can be affected. If the patient has got migraine for more than 15 days for every month for 3 or more consecutive months, that is called chronic migraine, which can be a really challenging thing to diagnose. And many of the times the chronic migraine can be because of the medication overuse headache. We'll talk about it in another slide shortly. Vestibular migraine can be quite challenging when the patient presents with vertigo, and in females they can have menstrual migraine. There are various complications of migraine which can present. Patient can have cerebral infarction. They can have aura without any cerebral infarction. They can have seizures. So we need to keep an eye on these conditions because patient may not present with migraine. They can present with a complication of migraine. All right. Now, this is a very busy slide, I know. The international classification of the headache disorder, they have got this classification that or the diagnosis rather, that migraine can be diagnosed with all these specific characteristics. So, for example, there should be at least 5 attacks of these conditions. So patient can have the migraine attack which lasts for 4 to 72 hours. They can have at least 2 of these following features. These are, it is unilateral location, pulsatile, as we have just mentioned earlier. They have moderate or severe pain intensity, and this is aggravated or caused by the avoidance of routine physical activity like walking or climbing. If any 2 of these 4 features are present, and most importantly, if one of these features are present, like nausea, vomiting, photophobia, phonophobia, and the last but not the least is no other alternative cause like subarachnoid hemorrhage or dural venous sinus thrombosis are present. So that is a way of diagnosis. I would not ask you to remember this or memorize it. You can just search in the Google if you have got any queries. Similarly, there is a migraine with aura. They have got a similar type of diagnostic characteristics. Again, I'll probably not be very focused in memorizing it. You can always get online help in the diagnostic criteria. What I'm trying to say is there is some diagnostic criteria which may be useful in the diagnosis of migraine. Now, as we have mentioned, that there are some diagnostic criteria for migraine with aura, and there are some diagnostic criteria for migraine without aura. Now, whenever you see the patient, the most challenging part is to differentiate or rule out the other differential diagnosis. Is it a subarachnoid hemorrhage? Is it a dural venous sinus thrombosis? Is it an acute angle closure glaucoma? Or is it a temporal arteritis in a patient who is more than 50 years of age? So that is when you need to do a thorough physical examination. If you do the thorough physical examination, and if you rule out all those primary or secondary differential diagnoses, then you may think, oh yeah, it could be a migraine. Most of the time, patient has a history of migraine which has already been diagnosed and might represent with a recurring headache. Now, a very important concept is a neuroimaging. Should you do neuroimaging in a patient who has got migraine? Usually, the answer is no, because there is no role of neuroimaging in the diagnosis of migraine. However, there are some roles of neuroimaging to rule out the differential diagnosis. So if you have got any concerns about the differential diagnosis, then you do the neuroimaging. There are certain factors, certain conditions where neuroimaging can be considered. Becky, could you please tell us about it? Thank you.
Usually, no neuroimaging is required for the diagnosis or management of migraine. However, there are certain situations where neuroimaging is warranted. For example, the first or worst headache in a patient with migraine may need a CT head to rule out a subarachnoid hemorrhage. Similarly, neuroimaging is required in a recent significant change in the pattern, frequency, or severity of headaches. In addition, new or unexplained neurologic symptoms or signs, headache always on the same side, headaches not responding to treatment, new onset headaches after age 50 years, new onset headaches in patients with cancer or HIV infection are few of the conditions that warrant neuroimaging such as a CT head. If there are associated symptoms and signs such as fever, stiff neck, papilledema, cognitive impairment, or personality change, then that may also need neuroimaging.
Excellent. So as I mentioned that if you would like to rule out the differential diagnosis, the neuroimaging like CT head or MRI or MRA CT, that may be required. However, for diagnosis of migraine itself, we don't need any neuroimaging. I've seen many patients who are known to have migraine, came to the ED with headache, we have treated as migraine, Later, it turned out that they have got subarachnoid hemorrhage, which is very unfortunate, but this happens. Um, After the age of 50 years, think about the temporal arteritis or giant cell arteritis. So you need to do not only the different tests, which may be the CT image, but also do the ESR or CRP. And these patients might need steroids, otherwise they might lose their vision permanently. If the patient has got fever and neck stiffness, think about meningoencephalitis. So they might not need only the CT head, but also might need a lumbar puncture. So it's not a very straightforward thing, but if as long as we keep an open eye and open mind in the diagnosis, then we will pull through this quite easily. Now, differential diagnosis, we can divide them into two different groups. The primary headache, there are three conditions that we need to keep an eye on. These are migraine headache, obviously, the tension headache, and cluster headache. Sometimes they can be very easy to differentiate. For example, in migraine headache, this is unilateral, pulsatile. In tension headache, this is band-like, circular, all around the head. In cluster headache, it comes in clusters. And secondary headache, this can be life-threatening or life-threatening conditions. So we need to be very, very careful about these conditions, especially subarachnoid hemorrhage. If there is head injury, then think about subdural hemorrhage. If the patient has got fever, neck stiffness, think about meningoencephalitis. If there is altered level of consciousness, think about meningoencephalitis or brain tumor or intracranial hemorrhage. I've seen patients with cervical artery dissection who present with neck pain and then they develop headache, which feels like migraine headache, but actually this is cervical artery dissection, maybe vertebral artery dissection or carotid artery dissection. So you need to keep an eye on it, especially if the patient comes with neck pain and headache. Please, you have a very low threshold to do the CTA and CT head as well. If the patient has got visual acuity reduction with headache, and if the patient has got, you see that there is haziness in the pupil, there is mid-dilated pupil haziness in the cornea, sorry. And if the patient has got raised intraocular pressure, think about the acute angle cortical glaucoma, which can be a sight threatening condition. So this is a medical emergency or the ophthalmological emergency. So we need to keep an eye on it. As I mentioned, after the age of 50 years, if the patient comes with headache, think about giant cell arteritis or temporal arteries as well. Now, as a physician, our main challenge or main goal is to give some treatment to make the patient feel better and also to rule out the differential conditions. We can divide these management options into three categories. The pharmacological therapy, which we are more familiar with in the emergency department or urgent care settings, non-pharmacological therapy, which is probably beyond the scope of emergency physicians or urgent care physicians, and the surgical therapy, which belongs to the surgeons. We'll get into further details about abortive therapy and rescue therapy. So abortive therapy is when the patient has got symptoms. To control the symptoms, we can give some treatment. We can give NSAIDs, we can give opioids, which is not ideal, but it can be given. We can give sumatriptan, we can give a lot of other different things. So that is the abortive therapy. Rescue therapy is to prevent the recurrence. We can give steroids like dexamethasone, we can give sodium valproate, we can give magnesium, we can give beta blocker, calcium channel blocker, we can give there are different options, and we'll get into the further details about it. So what I'm trying to say is abortive therapy is the acute treatment when the patient has got headache, and rescue therapy is to prevent the recurrence of it. The GPs play a very important role in the non-pharmacological therapy, and I'm pretty sure we can educate the patients about the non-pharmacological approaches as well. Yoga, meditation, there are some relief music, and in the YouTube there are lots of them. Acupuncture has got some role, and there is some psychological or psychiatric therapy, that is the cognitive behavioral therapy, which may be useful as well. Very rarely the patients will need some surgical therapy. Now let's talk about what happens in abortive therapy. If the patient has got mild or moderate attack, the first thing we can try is some simple painkillers. For example, we can try with some aspirin. Now this is not the small dose of aspirin like 100 or 300 milligram of aspirin. We are talking about 800 to 1000 milligram of aspirin. This is a very high dose of aspirin or very high dose of ibuprofen. So we can give 800 milligram of ibuprofen, or naproxen, 500 milligram of naproxen. That works really very well in many patients with mild to moderate attacks of migraine. The second medication that very commonly is given is paracetamol, but make sure that the patient is not overdosed with paracetamol, because the patient has got so much headache. Sometimes they take a very high dose of paracetamol, which can cause damage to the liver. So you need to educate the patient that take adequately but not excessively, and take the medication in a sensible manner. Now, in case of the moderate to severe attack, that is when patients turn up to the hospital. The first thing we can do is we can give 50 to 100 milligram of sumatriptan orally. Most of the patients with migraine, however, will have some nausea, vomiting. So in that case, giving oral tablet may not be the best option. So it's not the ideal medication. Instead, what we can do is we can give the sumatriptan injection. 6 milligram of sumatriptan subcutaneous injection, as is shown in this picture, that this auto injector, it is vertically placed on the upper thigh, and then you press the little button there, and it will give the injection on its own. Now, usually, most of the time, I found that this is very useful, and most of the emergency departments where I have worked over the last 12 years, they have got sumatriptan injections. If you don't have, you can ask the hospital pharmacist. They will give it to administer to the patients. Now, I found it really very useful to give some IV ketorolac if there is an absolute contraindication like anaphylaxis, or patient has got acute asthma. Now, if you give 30 milligram of ketorolac IV, usually that is very good, and it is actually better than the opioids. So these are the two medications which can commonly be used for moderate to severe attack, in addition to high dose of paracetamol and uh, aspirin, or naproxen, or some other NSAIDs. Now, one thing I should mention is that in case of moderate to severe attacks, we need to be very careful that we are not causing any harm to the patient. So give it sensibly and give the medications in such a manner that the patient can be benefited. We sometimes end up giving some opioids, which is not ideal because opioids have got many side effects. Opioid can actually shows, there are some studies which show that if you give opioid, it can cause medication overuse, headache, and the recurrence attack or recurrence admission of the patients to the hospital is much more increased if you give opioids. So personally, I don't like to give opioids until unless the patient is in severe pain and which did not respond very well to sumatriptan, ibuprofen, and paracetamol, or other medications like some metoprolol. We'll talk about it in a second. Recently, I started giving ketorolac if it is available in the hospital or the practice that I work, and usually that works. Now, one thing I need to make it absolutely clear that sumatriptan can actually mask the headache if you don't have migraine. So if the patient has got a suprachoroidal hemorrhage or suprachoroidal hemorrhage, they can feel better with the ketorolac. They can feel better with sumatriptan. So if the patient headache subsides with sumatriptan, does not necessarily mean that this is migraine. It may be something else. It may be subdural hemorrhage or suprachoroidal hemorrhage. So we need to keep a very open mind in this management option, and please be very, very cautious when we give the treatment. Now, a special condition of migraine is when the patient has got migraine for more than 72 hours, which does not improve with the treatment given. This is called status migrainosus. Now, the treatment is similar like in case of the severe headache. So we can give sumatriptan, we can give naproxen, or some NSAID, we can give paracetamol, and also we can give some ketorolac. And as you have mentioned earlier, that ketorolac IV 30 milligram, that is better, and it has got better safety profile than opioids. So personally, I like ketorolac if it is available. If it is not available, I give something else. Now, what would you do in the emergency situation in the emergency department or urgent care setting? So my practice is most of these patients have got nausea, vomiting, they are dehydrated, they are not eating and drinking. So I give some normal saline, maybe 1 liter slowly over an hour. I give some NSAIDs. My practice is to give some high dose of ibuprofen 800 milligram or aspirin 800 milligram to 1000 milligram. Naproxen can be given as an alternative, but don't give two different types of NSAIDs. Just give one type of NSAID, and usually that is pretty good. Antiemetics, we can give different types of antiemetic. My personal practice is to give 10 to 20 milligram of IV metoprolol. Usually that works very well. Sometimes I give IV chlorpromazine, 12.5 milligram in a liter of normal saline over 1 to 2 hours slowly. Some of the clinicians I know that they give prochlorperazine or stimetil, 12.5 milligram IM or 10 milligram IV. Many countries actually don't recommend giving a stimetil IV, and it is not approved. But in some of the places, I know that it is approved. And obviously, we can give the sumatriptan. About 70% of the patients respond very well with sumatriptan, and the dose is 6 milligram subcutaneously with an auto-injector. There are some alternatives for sumatriptan. I like sumatriptan because sumatriptan you can give in different ways. You can give subcutaneously, you can give intranasally, you can give oral tablet form. Most of the patients when we see in the emergency department, they have got nausea, vomiting. So giving the medication orally may not be a very good option. So I personally prefer giving sumatriptan. Now, one thing I'd like to mention is that if you give metoclopramide or chlorpromazine or prochlorperazine, they are well known to cause dystonia. So my practice is whenever I give those drugs, I also give some diphenhydramine IV, 12.5 milligram. That way is to prevent those dystonic reactions. If you don't give diphenhydramine and if the patient develops dystonic reaction, just give some benztropine, 1 to 2 milligram IV, or in some other countries, for example, in the United Kingdom, I used to give procyclidine, 10 milligram IV. That works very well as well. So let me summarize. So in the emergency situation, my practice is I give IV normal saline 1 liter, give some high dose of NSAIDs. We can give some paracetamol as well, but most of the time patient already has got some paracetamol. Then I give some antiemetics, maybe metoclopramide or chlorpromazine or prochlorperazine associated with some IV diphenhydramine 12.5 milligram, and I give some sumatriptan. So this is a cocktail of medications which works really very well. Now, another practice that I have started recently is to give some steroids, especially IV dexamethasone. And there is a very good literature to support it. This is one of the papers that Becky is going to talk us through in details. It was published in 2008, which is about 12 years ago from now, in British Medical Journal. And I found that this article really good, and it changed my practice a lot. It is a meta-analysis and of randomized control trial. Becky, could you please tell us about the details and how it has changed your clinical practice? Thank you.
Coleman and co-authors have published this meta-analysis of randomized controlled trials of the efficacy of parenteral dexamethasone in the management of migraine recurrences. This article was published in the BMJ in 2008. A little old article, but still worth having a look.
I agree.
The authors have performed the meta-analysis using the standard protocols and a thorough methodology. Their selection criteria were the randomized controlled trials in which corticosteroids, alone or combined with standard abortive therapy, were compared with placebo or any other standard treatment for acute migraine in adults. They evaluated abstracts of 666 articles and found that 7 articles fulfilled the selection criteria. All included trials used the standard abortive therapy and subsequently compared single-dose parenteral dexamethasone with placebo, examining pain relief and recurrence of headache within 72 hours. Dexamethasone and placebo provided similar acute pain reduction. Weighted mean difference was 0.37, 95% confidence interval minus 0.20 to 0.94. Dexamethasone was, however, more effective than placebo in reducing the recurrence rates. Relative risk 0.74, 95% confidence interval 0.60 to 0.90. Side effect profiles between dexamethasone and placebo groups were similar. The authors came to the conclusion that when added to the standard abortive therapy for migraine headache, a single-dose parenteral dexamethasone is associated with a 26% relative reduction in headache recurrence within 72 hours.
Excellent.
The number needed to treat was 9. This was a great article. It certainly changed my practice. I usually give 10 to 24 milligram of intravenous dexamethasone prior to discharge of the patients.
Excellent. That's a very good summary. So yeah, this particular paper is worth going through, and I found that if you give, if the patient has headache subsided, and if you decided to discharge the patient home, you can give 10 to 24 milligram of IV dexamethasone. That will reduce the recurrence of headache and readmission to the hospitals within the next 72 hours. So I think there is enough pathophysiological evidence to support that it actually works, and also there is a lot of clinical evidence to support that it works. There are a lot of research on this topic. And there is another recent new articles. I think that this was published in 2015. So I think it is worth looking at it as well. And this particular article also showed that if you use some IV dexamethasone, then it can be very useful. However, at the same time, I need to be very clear that other steroids like oral prednisone is not that good. If you give IV dexamethasone, that is good. The other option is to give some methylprednisolone. So Becky, could you please tell us a little bit more details about this particular paper? Thank you.
This article was published in 2015 in the journal Cephalalgia, which is the official journal of the International Headache Society. In this systematic review, 25 studies were selected. The total number of patients were 3,989, median age 37.5 years. The median male-female ratio was 1:4.23. Among these cases, 52% were ED-based, and 56% were randomized controlled trials.
Right.
4 systematic reviews were included in this article as well. The International Classification of Headache Disorders criteria were applied in 64% of the cases. 19 studies, 76%, indicated observed outcome differences favoring benefits of corticosteroids. 24% studies indicated non-inferior outcomes for corticosteroids. The median absolute risk reduction was 30%, range 6% to 48.2%, and 11%, 6% to 48.6%, for 24 and 72-hour headache recurrence, respectively. Parenteral dexamethasone was the most commonly, 56%, administered steroid, at a median single dose of 10 mg, range 4 to 24 mg. All the meta-analyses revealed efficacy of adjuvant corticosteroids to various abortive medications, indicating generalizability. The adverse effects were tolerable. Higher disability, status migrainosus, incomplete pain relief, and previous history of headache recurrence predicted outcome favorability. The authors came to the conclusions that the literature review suggested that with the corticosteroid treatment, recurrent headaches become milder than the pre-treated headaches and later respond to nonsteroidal therapy. Single-dose intravenous dexamethasone is a reasonable option for managing resistant, severe, or prolonged migraine attacks. Again, a fantastic article that changed my practice. Although various types of steroids can be given, such as IV dexamethasone, oral prednisone and IV methylprednisolone, IV dexamethasone is found to be more useful in reduction of migraine recurrence. This is my current practice as well. Thank you.
Excellent. So that was a very good summary of this paper. Again, this is I think this is a freely available paper, and you can download it from the internet and go through this. It has got a lot of goodies in it, and obviously it has changed my clinical practice. I'm pretty sure it will do the same for you as well. Now, another new advance in the management of migraine is magnesium sulfate. Will you use magnesium sulfate? There are different preparations of it. You can give magnesium sulfate IV for acute attack of migraine as an abortive therapy, or if you can give magnesium hydroxide oral tablet form, that can prevent the occurrence of migraine. So there are 2 formulations of migraine, and this particular paper it was looking at the different forms of magnesium, intravenous and oral. And as I mentioned, intravenous for acute abortive therapy and oral for rescue therapy or for prevention. So this is a meta-analysis, and Becky is going to talk us through. Thank you.
Kiyu and co-authors published this meta-analysis of the randomized controlled trials in 2016 in the Pain Physician Journal. Their main aim was to evaluate the effects of intravenous magnesium on acute migraine attacks. They also looked at the effects of oral magnesium supplements on migraine prophylaxis. They searched various databases from the inception to the 24th of February 2015. This review was conducted according to the guidelines of the PRISMA. Only RCTs evaluating the effects of intravenous or oral magnesium on migraine compared with a control group were included. A total of 21 studies were included in the meta-analysis. Out of them, 11 studies investigated the effects of intravenous magnesium on acute migraine, 948 participants, and 10 examined the effects of oral magnesium on migraine prophylaxis, 789 participants. Intravenous magnesium significantly relieved acute migraine within 15 to 45 minutes, 120 minutes, and 24 hours after the initial infusion. Odd ratios was 0.23, 0.20, and 0.25, respectively. Oral magnesium significantly alleviated the frequency and intensity of migraine. Odd ratios were 0.20 and 0.27. The authors came to the conclusions that the intravenous magnesium reduces acute migraine attacks within 15 to 45 minutes, 120 minutes, and 24 hours after the initial infusion. They also found that the oral magnesium alleviates the frequency and intensity of migraine. They recommend that intravenous and oral magnesium should be adapted as parts of multimodal approach to reduce migraine. Honestly speaking, I have not used magnesium in the management of acute migraine or its prevention. However, this is something we may consider. There is good evidence to support its use. Thank you.
Excellent. So yeah, so magnesium is, I know some of the clinicians, they use magnesium, but the place where I'm working at this moment, it is not routinely practiced. But as you have mentioned that there is enough evidence to support that magnesium actually works, both for the acute treatment and for the prevention or rescue therapy. So this is something we may consider. And even if we don't give it, if the patients are aware of it, sometimes they take the tablet form, which is available over the counter. So that can be useful as a treatment option, as a prevention as well. Now, another medication which is worth noting is the sodium valproate. Sodium valproate can be given in two different forms. You can give IV sodium valproate 1 gram over half an hour for acute migraine attack as an abortive therapy. The other option is you can give 400 milligram of sodium valproate tablet form as a rescue therapy for prevention of migraine attacks. So in this particular study, the authors have compared between magnesium oxide and sodium valproate, and they found that there is not much difference between these two. So basically, sodium valproate is as effective as magnesium. Now, Becky is going to talk us through this particular paper as well. This is pretty recent article. This was published just last year. So it is pretty contemporaneous evidence. Thank you, Becky.
This is a randomized controlled trial which was published in 2019 in the Acta Neurologica Belgia. This is a single-center, randomized, controlled, crossover trial which is double-blind, 2-period, 2-treatment. After the patient randomization into 2 sequences, the intervention group received magnesium oxide 500 mg and the control group received valproate sodium 400 mg 2 tablets each day, every 12 hours, for 8 weeks. The primary efficacy variable was reduction in the number of migraine attacks and number of days with moderate or severe headache and hours with headache, duration, per month in the final of 8 weeks in comparison with baseline. 70 patients were randomized and 7 dropped out, leaving 63 for analysis. In an intention to treat analysis, 31 patients were in Group 1, magnesium oxide then valproate, and 32 patients were in Group 2, valproate then magnesium oxide. The mean number of migraine attacks and days per month was 1.72 plus minus 1.18 and 2.09 plus minus 1.70. With a mean duration of 15.50 plus minus 21.80 hours in magnesium group and 1.27 plus minus 1.27 and 2.22 plus minus 1.96.
Right.
With a mean duration 13.38 plus minus 14.10 hours in the valproate group.
Oh.
This study has shown that 500 mg magnesium oxide appears to be effective in migraine prophylaxis, which is similar to valproate sodium without significant adverse effect.
Excellent.
Therefore, sodium valproate can be recommended in the IV route for acute migraine, while oral sodium valproate can be used in prophylaxis of migraine attacks.
Excellent. So that is the latest article that we have got on the effect of sodium valproate. And the author suggested that we can give sodium valproate orally for the prevention of migraine. So this can be one of the rescue therapies that we'll talk about in a second. Now, should we give opioids? That's a big $1 million question. The evidence suggests that no, don't give any opioid, don't give any morphine or fentanyl in a patient with migraine. But reality is that if the patient is in a lot of pain, we don't have any other option. Now, this was the article, it was published in Cephalalgia, and this particular study was based on the American emergency departments, and they have tried to find out what is the recent practice or current clinical practice. And they found that although the guidelines say don't use opioids because of its side effects, the clinical practice is that clinicians give opioids anyway, which is quite alarming because of the various side effects of opioids that we are aware of. So Becky, could you please tell us in a comprehensive manner the findings of this particular study? Thank you.
This article was published in the Cephalalgia Journal in 2015 by Friedman and co-authors. They noted that the published data from 1998 revealed that most patients treated for migraine in an emergency department received opioids. Over the intervening years, however, a large body of evidence has emerged demonstrating the efficacy and safety of non-opioid alternatives. Expert opinion during these years has cautioned against use of opioids for migraine. The authors in this study aimed to compare the current frequency of use of various medications for acute migraine in the United States emergency departments with use of these same medications in 1998 and to identify factors independently associated with opioid use. They analyzed the National Hospital Ambulatory Medical Care Survey data from 2010. They included in the analysis all patients with the ICD-9 emergency department discharge diagnosis of migraine. Using a logistic regression model, the authors explored the independent association between any opioid use in 2010 and sex, age, race, ethnicity, geographic region, type of hospital, triage pain score and history of emergency department use within the previous 12 months. They found that in 2010, there were 1.2 million migraine visits to the USA emergency departments. The opioids were administered in 59% of visits. The most commonly used parenteral agent, hydromorphone, was used in 25% of visits in 2010 versus less than 1% in 1998. Conversely, the use of meperidine or pethidine had decreased markedly over the same time frame. In 2010, it was used in just 7% of visits compared to 37% in 1998. Metoclopramide, the most commonly used antidopaminergic, was administered in 17% of visits in 2010 and 3% of visits in 1998. The use of enitriptan was relatively uncommon in 2010, 7% of visits, and in 1998, 10% of visits. Of the predictor variables listed above, only emergency department use within the previous 12 months was associated with opioid administration, adjusted odds ratio, 2.87. The authors came to the conclusions that in spite of recommendations to the contrary, opioids are still used in more than half of all emergency department visits for migraine. Though use of meperidine or pethidine has decreased markedly between 1998 and 2010, it has largely been replaced by hydromorphone. Opioid use in migraine visits is independently associated with prior visits to the same emergency department in the previous 12 months. This is a nice review showing the practice in the US emergency departments. Honestly speaking, I found that the use of opioids in migraine still quite high in my work practice, though we are aware of the side effects and complications of such practice.
Absolutely. So it's very alarming that the opioids are still used in a very high frequency, but probably we don't have much option because the patient is in so much pain that we want to help the patient and we end up giving some opioids. But as I mentioned, if you give some other drugs like some IV ketorolac or IV chlorpromazine, that can be as good as opioids. So I think we need to think about it to reduce the use of opioids and to go for the non-opioid medications in migraine headache. Of course, if we are not sure whether it is migraine or something else, we might end up giving some opioids anyway. So this is something to consider. Thank you. Now, whenever we talk about opioids, we need to talk about the medication overuse headache. Now, what is medication overuse headache and why we should be worried about it? So first of all, these are the patients who have got a history of headache. It may be migraine headache, it can be tension headache, it can be cluster headache, some form of headache is there. And the patient is also on medication, which may be paracetamol, ibuprofen, sumatriptan, opioids. And even after taking medications, these patients are having chronic headache for more than 15 days per month for more than 3 months. So that is, by definition, the medication overuse headache. Why you should be worried about it? Because, as you mentioned, this is actually taking the medication that is causing the headache. So if we can reduce the medication, especially opioids, then their headache will improve. So if we know the cause, we can give the treatment, and we know the cause is actually the medication itself. So reduce the medication. These patients present with worsening headache, especially when they wake up from bed during doing physical activities, and the patient can have nausea, vomiting associated with headache, and patient can be very restless. Anxiety may be there, there may be irritability and poor concentration, just like the withdrawal symptoms of alcohol. So if the patient comes with these features, think about the medication overuse headache. Among different medications, the opioids like morphine, codeine, tramadol, they are associated more with the medication overuse headache rather than NSAIDs. So NSAIDs are least associated with medication overuse headache. So my practice is that this is the safest medication to give is NSAID. Even sumatriptan is associated with medication overuse headache. So we need to be very careful about that as well. Now, how are we going to treat it? How are we going to manage it? So there are 3 steps. First of all, patient education. So this should be a shared decision making. Educate the patient, and patient will be able to participate in the decision making process. This is not a unidirectional treatment. This is a bidirectional treatment. This is a teamwork. This is a joint work. So explain to the patient what is happening and what are the different options in the management. So patient education is very important. Second thing is the prevention. So we can give, for example, sodium valproate, dexamethasone, or some other medications, a beta blocker, calcium channel blocker. So that can prevent the recurrence of it. And third is, even if the first and second steps fail, then we can admit the patient or just give the detoxification in the outpatient clinic. So many of the patients need admission to the hospital for detoxification. So these are the 3 steps which can be used for the management of the medication overuse headache. And again, this is not the decision of the emergency physician or the urgent care doctor or by the GP to do the treatment of the medication overuse headache. Probably this is the best time to get the other team members involved. For example, a neurologist, a psychologist, or a physiotherapist, they might be useful.
Medication overuse headache is defined by the International Classification of Headache Disorders as a headache in patients with a pre-existing primary headache disorder that occurs on more than 15 days per month for more than 3 months.
Yeah.
It is caused by the overuse of medication intended for acute or symptomatic headache treatment. The prevalence of medication overuse headache in the general population is around 1%. But, the condition is much more common in people with headache, in particular chronic migraine. The phenotype of the headache in medication overuse headache depends on the initial primary headache and the type of overused acute medication. The treatment of medication overuse headache is performed in 3 steps. Number 1, educating patients about the relationship between frequent intake of acute headache medication and medication overuse headache with the aim to reduce intake of acute medication. Number 2, the initiation of migraine prevention, such as topiramate or onabotulinum toxin in migraine, in patients who fail step 1. Number 3, detoxification on an outpatient basis or in a day hospital or inpatient setting, depending on severity and comorbidities. The success rate of treatment is around 50 to 70%, although patients whose medication overuse headache is associated with opioid overuse have higher relapse rates. In all patients with medication overuse headache, relapse rates can be reduced by patient education and care in the follow-up period.
Excellent. So that is about the medication overuse headache, which sometimes we overlook, but we should not overlook. This is something that we need to work on it, and this should be a shared decision making between the patient and the doctor, and this should be dealt with in a very rigorous manner so that the patient ultimately can get to the benefit. Now, let's talk about a little bit about the rescue therapy. So far, we have talked about abortive therapy. The rescue therapy is when the patient's headache subsides, we can give some medication so that it does not relapse. One of the medications that we can use is the beta blockers, such as metoprolol, propranolol, atenolol, they can be given. Calcium channel blocker, especially verapamil, can be given as well. And there is a lot of antidepressants. And as we have mentioned in pathophysiology section, that the main cause of the migraine headache is because of the reduction of serotonin. So if you give some medication that increases serotonin, like SSRI, SNRI, tricyclic antidepressant, usually that can uh, prevent the relapse of the headache. So that usually very effective. Amitriptyline is something that I prescribe personally to the patients. Of course, there are some other medication like SSRI, SNRI. Venlafaxine is a very good one that can be used as well. There are some antidepressants, anticonvulsants. For example, sodium valproate, 400 milligram, that can be given. Magnesium has got some role as well. If we give oral magnesium, that can be used as a rescue therapy as well. Now, I need to update the audience about the new techniques on this management of migraine headache. One is a botulinum toxin. I know one neurologist who specializes in botulinum toxin administration, and apparently, what I understand is that it works very well for the patients. So he has got his little clinic where he does the botulinum toxin injection to the scalp, and it works very well. The other practice which I have done personally is the greater occipital nerve block. So basically, it takes some local anesthetic and put the injection in the back on the side of the greater occipital protuberance, and that works very well, especially if the migraine involves the upper cervical nerve roots. Spinoparietal ganglion nerve block, it can be used into the nose. And I know some of the ENT guys, they are very passionate about it. As I mentioned earlier, that magnesium can have some very important role, and melatonin can have some important role in the treatment and management or prevention of migraine as well. One thing is interesting about migraine is if the patient has got a very good sleep, their migraine subsides. So I think that is how melatonin works in case of the migraine as a rescue therapy. There are a lot of non-pharmacological treatment. This may be beyond the scope of the emergency medicine clinicians or the clinicians working in the urgent care settings. But again, we can educate the patient and they can get the help from the appropriate people. For example, acupuncture was found to be effective. Yoga, meditation, this was found to be effective. In YouTube, there are a lot of videos, something called the migraine relief music. You can listen to that, and that can be useful as well. The physiotherapy, psychotherapists, and the psychiatrists, they can provide the cognitive behavioral therapy, and this is found to be very effective in the management of migraine. One option which is non-pharmacological is it's like TENS machine. So you give this transcutaneous supraorbital nerve stimulation, just like TENS machine, which is used in back pain, and usually that is quite good in the management of migraine as well. A very important thing we have talked about in pathophysiology that uh, with time there is sensitization. So the threshold level for the migraine that decreases. So the same trigger can cause migraine, and few months later, even a small amount of the same trigger can cause migraine. So that is sensitization theory about migraine. So the treatment is desensitization. And unfortunately, this is probably beyond the scope of emergency medicine clinicians or urgent care clinicians. But again, the GPs can help, or the psychotherapists, they can help in the desensitization process, that the trigger threshold can be increased. So even if the patient is exposed to the same trigger, they don't develop migraine, and you need a very strong trigger to develop the migraine. So that is a desensitization process. So let's summarize everything together. So migraine can be a very challenging diagnosis. This is the headache for the patient, but also headache for the clinicians. We need to keep an open eye about the differential diagnosis. We know that the diagnosis is difficult or challenging. We know that treatment is challenging. And also we know that the complication can be challenging. Patient can have a cerebral infarction from migraine. They can have seizures from migraine. So we need to keep an open eye. We need to consider the abortive therapy as well as rescue therapy. There are some new evidence to suggest that IV dexamethasone can be useful, magnesium sulfate can be useful, sodium valproate can be useful, and we need to keep an open eye in the use of those options. And of course, we can take the shared decision-making process by informing the patient, educating the patient about the various non-pharmacological therapy. Now, Becky, could you please summarize everything for us? Thank you.
Okay everyone. It is time to wrap up now. So, migraine is a disabling condition. Although the headache is the centerpiece of migraine, there may be migraine without headache too. There are various types of migraine such as migraine without aura, migraine with aura, hemiplegic migraine, retinal migraine, menstruation migraine, chronic migraine etc. There are 4 phases of migraine. These are, number 1 the prodromal phase, number 2 aura, number 3 headache and number 4 postdrome. Remember the mnemonic pound for migraine. P for pulsatile, O for onset 4 to 72 hours, U for unilateral, N for nausea vomiting and D for disabling. Unfortunately, there is no blood test or imaging techniques to confirm the diagnosis of migraine. The diagnosis is based on history and clinical examination. However, there are some conditions which warrant urgent neuroimaging such as sudden onset severe headache, immunosuppression, history of HIV or malignancy, age more than 50 years. Migraine treatment has 2 options. First is the abortive therapy with paracetamol, NSAIDs, triptans and ergotamines. Second is the rescue therapy with beta blockers, calcium channel blockers, and anti-epileptic drugs. Steroids such as intravenous dexamethasone 10 to 24 mg reduces the recurrent visits of migraine patients. When caring for the migraine patients, we need to keep an open eye for the differential diagnoses such as subarachnoid hemorrhage, dural venous sinus thrombosis, meningitis and space-occupying brain lesions. Migraine can be challenging to diagnose and treat. However, a systematic approach may be very useful.
Excellent. That's a very good summary. And the most important part is a shared decision making and keeping an open eye about the differential diagnosis. Then we can diagnose it, treat it, make the patients feel better. And if there's any complication, we can manage this as well. Thank you very much. Now, there are a lot of articles in the internet. I use most of the articles from the UpToDate, and there are quite a few articles from Coleman, Friedman, and Chiu. And please go through those articles. These are freely available in PDF form in the internet, and some of them can actually change your practice. So it is worth looking at it. Now, if you have got further questions, please drop me a line, write some comments, positive or negative, and we'll get back to you as soon as we can. All right, it's time to wrap up now, and thank you very much for all of your time that you have spent in watching the video. If you have any further questions, please get in touch. And thank you, Becky, for doing all the literature review and helping me in the presentation. Thank you very much.
Okay folks. Thank you for watching the video. Hope you have enjoyed the video. You are so awesome. If you find it useful, please like the video, subscribe to the channel and share it with others. Please write comments below the video. For every comment that you write, positive or negative, I will personally give a cookie to my cat Lucy. I promise I will do. If you have any burning questions, constructive suggestions or some awesome ideas, please get in touch. We would love to hear from you. Your comments and suggestions are very important to us. You can contact us through email, Twitter or Dr. Barai's webpage. Thanks once again. See you soon. Bye for now.